My name is Paul Ford, and I'm a clinical ethicist at the Cleveland Clinic. Over the past 20 years, I've spoken to thousands of patients and family members struggling with tough medical choices. Many of those choices were for people with dementia or other progressive illnesses. Sometimes I reassure people of the clear choices they are making. Other times I help them to reframe their decision-making based on changed medical circumstances. Most medical ethics choices come later stages of dementia when loved ones struggle to know how to respond to changing medical circumstances. You can hear these struggles vividly as people grapple with how to respond to new situations. A daughter looks at her mother with a baby doll and blurts out, "This is so undignified. She was a proud woman." At the same time, that daughter also is struck by how contented and peaceful the doll makes her mother. It gives some peace and solace. A man living with dementia keeps demanding his daughter give him the keys to his car, and then claims his car was stolen. The daughter is troubled to know how to respond in a compassionate way. She knows the car has long been sold, and her father has not driven in years. How is she to respond? A woman living with dementia keeps insisting that she doesn't need pills with great agitation, telling her son she absolutely will not take them. Her son knows that the pills are needed to offset this agitation and that his mother continues to forget why she needs them. Maybe he needs to hide the medicine in her applesauce, but it doesn't sit right with him to deceive his mother. The sister of a woman living with dementia turns angrily to the doctors who have just recommended against force feeding, either by mouth or tube. How can they think to starve her beloved sister? At the same time, the sister also does not want to force the woman's mouth open or force her to do anything against her will. These quotes highlight the common value assertions that trouble people in later stages of dementia and those who care for them. This is when a clinical ethicist may be asked to help people living with dementia and their loved ones. As you can tell from the stories, there are at least 3 broad areas that are worth mentioning, where decisions can be non-intuitive. Our first gut responses need to be reconsidered given new circumstances. These 3 areas are dignity, truthfulness, and providing comfort through food. A tough ethical choice always means we're sacrificing one thing of importance, value, to preserve another thing of value. And it's not always intuitive. Our gut responses often lead us astray when we encounter new circumstances. We are pulled to follow our habits that work well in the usual cases. But these are now unusual cases. We need to step back and consider the perspective of the person living with the dementia. So let's start with dignity. Dignity is always anchored in the person's own perception and within societal attitudes. We need to ask, what is this person's current experience? Do we need to change the person's circumstance, or does society just need to accommodate this difference? The most important question remains, is this person being cared for in the way they want and need? It is from their perspective and experience of what is dignified, not some past experience. Truthfulness. For me, I don't want to lie to my parents. It is ingrained deeply in who I am. But sometimes this needs to be reframed without disrespect to the person's past experience. When I lacked understanding as a child, my parents took care of me. They took care of me in ways that were respectful to me and respectful of the limits of my understanding. When my parents lack understanding as adults, I will need to care for them with the same compassion and respect. So truthfulness is about expectations and limits of ability. Food. In many ways, food can be the most troubling aspect of care for loved ones, particularly when a person living with dementia no longer expresses a desire to eat. This is common in the latest stages of dementia. Although through much of our lives, food could be equated with comfort, it does not always equal comfort in later phases of life. This is particularly true when a person might not feel hungry, or in fact, when they feel full. Rather than focusing on meals, full meals, there are circumstances where the focus becomes simply the pleasure of eating. In fact, comfort feeding can be satisfying to all, the person being fed, as well as the caregiver giving the food. This is where very small samples of food are offered to a person so they can enjoy the sensation, but never forcing someone to take anything. For many people living with dementia, there is a time when it becomes an extraordinary measure to force nutrition and does not change the outcome to push, and particularly true for artificial nutrition. Around food and comfort, it should always be about goal and experience of the person living with dementia, and not our social norms or how we emotionally feel about food. Dementia's counterintuitive challenges can be troubling as the dementia progresses. And advancing dementia does not keep people and their loved ones from living lives that are rich. The focus needs to be on shifting goals of caring. The examples I have given are intended to push you to challenge some of your usual assumptions. Many of us will be faced with these choices for our loved ones, or we will ask our loved ones to make them for us. It is important for us to provide care from the perspective of our loved one, and in order to do that, we need to pay careful attention to their current stories and experiences. Thank you for allowing me to share these stories.